The views expressed on the Jerry Cahill's CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill's CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor.
Welcome to Jerry Cahill's Living, Breathe, and Succeeding podcast series, The Path Forward with CF. This show was made possible through an educational program from Columbia University Medical Center and the Lung Transplant Project to the Boomer Esiason Foundation. I recently sat down with Dr. Emily DiMango and discussed the lung transplant waitlist, pre-transplant management, and when is it right to be referred. We discussed various topics like your lung function, your nutrition, your PFTs, and also being resistant to medications. I hope you find this podcast insightful and helpful.
I'm Dr. Emily DiMango. I'm a pulmonologist and I'm the director of the Gunnar Esiason Adult Cystic Fibrosis program here at Columbia University. I've been involved in CF since 1993 when during my training I actually did laboratory research trying to understand how Pseudomonas causes airway inflammation in people with CF. And from there, that was before there were a lot of adult CF centers, I actually trained with a pediatrician when I became interested in the disease to learn how to take care of patients, and eventually started the adult CF program in 1999. Currently, we take care of about 250 adult patients with cystic fibrosis. We have, over the years, done a lot of our own independent research trying to understand how CF is different in adults, especially in people who are diagnosed as adults. And we actually have a very large clinical trial effort at our center. Each year, anywhere from 15 to 20% of our patients participate in clinical trials. And we and many other CF centers feel that that's a really important part of care, not only to get these cutting-edge medications to our patients as soon as possible, but also, of course, to help us learn to treat CF in more effective ways to hopefully turn this into a chronic illness rather than a life-shortening illness, and eventually, hopefully, we will be able to find a cure. There typically is not an exactly right time to be referred for transplant. We usually use an FEV1 cutoff of 30% of predicted as the time to start talking to our patients about going to the lung transplant center and being evaluated for transplant. But that 30% predicted statistic happens to come from research that was done over 15 years ago. We know now that people who have a lung function of 30% of predicted, probably that's a little early, especially with all of the drugs that we have available to refer for transplant, but nonetheless, it's always safer and it's always best to refer people for transplant evaluation before they actually need the transplant, because it's a process. It requires a lot of testing, blood tests, radiology testing, psychosocial screening. Patients have to participate in a lot of education classes, so it takes quite a bit of time to be accepted as a transplant candidate. And in my opinion, and I think in the opinion of many doctors who take care of people with CF, it's really better to refer people early when they're healthy to go through the testing, and then we just sort of put things on hold, but at least everything is up to date. People can follow with the transplant center every 3 or 6 months depending on their needs and on their medical status. And when and if the time does come, all of the hard work has been done. So if you think about it, there's really no downside to referring somebody too early other than the psychological impact of being on a lung transplant list. And I think that's part of the process, and the sooner we address that, the better. When I talk about referral for transplant, I basically mean the CF center fills out the paperwork, talks to our patient about what the process will be like as best as we can, and sends the paperwork over to the lung transplant center. Then there's a process of insurance approval that can take up to 2 months, and then the patient is called by the transplant center for a visit where all of the testing and psychosocial screening and so forth starts to happen. So when I talk about referral to transplant, I basically mean recommending to the patient that it's time to see the transplant team, both to become independently educated about transplant so they can make an informed decision about whether this is right for them, and also to do the testing that is required. Again, this is typically done well before a patient needs to have the lung transplant, but because of the process, it's always best to refer a patient to the transplant center early. And also, there is an unpredictable nature to CF. Sometimes people get a bad influenza that can really cause a significant decline in lung function, and you don't want to be caught at the midnight hour when a patient is not doing very well, scrambling to get all of this testing done. Reactions from patients are really all over the place. Some patients have told me, oh yes, I know, my pediatrician told me for as long as I could remember that someday I'm going to need a lung transplant. So they've been prepared for this mentally all along. And a lot of times we start having discussions about transplant when we see the lung function declining, or we see a patient becoming hospitalized more frequently or having other complications of CF. So the reaction really varies from disappointment, feeling that their bodies let them down, or that they did something wrong, that it's come to this point now where they need a lung transplant, or expectation that this is just a natural course of the disease and this was going to happen at some point. The steps involved in becoming listed are some paperwork and administrative issues, but from the patient's health perspective, and we do this all along in taking care of people with CF, we really try to optimize their health. It's probably more important than ever to be in good nutritional shape, to be well conditioned physically, specifically to exercise, and it doesn't have to be anything fancy. It just has to be some sort of daily activity that gets your heart rate up, or near daily activity. Because in my experience, and I'm not aware of any data that supports this, but in my experience, patients who have been exercising and who have good nutritional status don't need to be in the hospital as long after they have their lung transplant. Their post-transplant recovery tends to be a lot faster if they're healthier from every other perspective outside of their lungs going into the lung transplant. So the process involves getting diabetes under control if it's present, and hopefully it has already been under control, getting nutritional status optimized, treating infections very aggressively. We tell patients, as we always do, to let us know if they're not feeling well. It's very important in CF to try and slow down disease progression, to get on these infections early, to start antibiotic treatment once symptoms start to develop. And an exercise program is so important. Many people with CF already do exercise on a regular basis, and for those who don't, especially for those who feel too short of breath to do any substantial exercise, we refer them to pulmonary rehab programs where they can really exercise under monitored, controlled conditions and really learn how to exercise with the limitations of their lung disease. Once patients are waiting for a lung transplant, there can be a fairly long wait for a transplant, especially in highly populated areas like New York City. So sometimes patients will double list, and what that means is being listed at their primary lung transplant center, but also being listed at one or sometimes even two other lung transplant centers. And that can happen, and that's actually a good thing, because it really means that 3 different regions are looking for lungs for that patient at the same time. And the wait list, your position on the wait list may be different at those 2 or 3 different lung transplant programs. Yes, when talking about time for transplant referral, there are certainly some people who are very opposed to having a lung transplant. They have thought about it for years and have already made the decision that this is something they don't want. That's very difficult as a physician to handle, especially because we're really trained to promote and prolong life. And what I personally do in those circumstances is still insist or try to really convince the patient to be seen by the lung transplant program. Everybody has a right to their decision, but I think it's important to make an informed decision. So before someone makes an important decision like that, I think it's very, very critical that they be seen by the specialist so they really understand what a lung transplant is and can make a decision based on that information. When patients are waiting for a lung transplant or, waiting for the call to come in for a lung transplant, we see them in the CF center probably once a month, because typically at that point people have pretty advanced lung disease, sometimes even more often than once a month. And we're really very attentive not only to their pulmonary health, to their lung function, but really to their health in general. Our social worker talks to them a lot about anxiety and depression that might be associated with waiting for a lung transplant. We're very attentive to their nutritional status, make sure that their kidney function and liver function and so on are all normal so that they're safe to have a lung transplant. We also really work with our patients to come up with an exercise regimen, whether it's under a supervised setting in pulmonary rehab or something they're doing in their basement on a treadmill. We really encourage our patients to stay as active as they can while they're waiting for a transplant. We also address things like oxygen needs. Some people need some help breathing overnight with a device called a BiPAP machine. And sometimes that becomes necessary in the months leading up to a transplant. We also correspond very regularly with the lung transplant team by email, by phone calls. Each of the two teams, the cystic fibrosis team and the lung transplant team, keep each other up to date on what's going on with the patient, particularly because a lot of measurements that we take in CF clinic go into the scoring system for a lung transplant. So for example, every time we do a pulmonary function test in CF clinic, we send that information to the transplant team so they can update the patient's score. So there's a lot of back and forth, and it's very important to have good communication between the lung transplant team and the CF center. When a patient is waiting for a lung transplant, the things that they can do to stay as healthy as possible are keep up with their treatments, with their airway clearance and their aerosol treatments, get enough rest, make sure they're getting enough nutrition, that they're seeing their CF team regularly to address any issues that might be coming up. And it's also very important, I talked about some patients feeling like they're in a limbo phase while they're waiting for lung transplant. It's very important that the patients address their own emotional needs and really stay engaged with their families, friends, the rest of the CF community, if that's something that they derive support from. I know a lot of that is done through social media. So in addition to really taking care of their physical health, I think it's important for patients and for their families to be aware that their emotional health can really suffer during this very difficult time. There can be a lot of depression, anxiety, tearfulness. And we encourage, and hopefully the transplant team encourage patients to talk to us about these things. Both teams have people in place, professionals in place, to help patients address these needs, and sometimes medication might be necessary. So there are a few misconceptions that patients have about having a lung transplant. The biggest one that I see is patients are worried about not surviving the actual operation. They're afraid of, dying on the table. And again, the lung transplant team is really in the best position to provide information about that. But if you look at national statistics, well over 90% of people who have had a lung transplant are alive 1 year later. So the chances of not making it through the surgery are pretty low. Another concern that people have about lung transplant is the pain associated with the surgery. Any surgery, even minor surgery, is associated with pain. And we try, again, this is part of education before transplant. We and the lung transplant team, more importantly, really explain to the patients that we recognize pain is a potential problem or will be a problem after transplant. And we use pain medications quite liberally after transplant or surgery. After lung transplant, some patients even have what's called a PCA, which is a self-administered device for administering pain medications. So we really think we're pretty good at addressing pain in the first few days after transplant. After transplant, we request that our patients come to their CF center once a year. We do things like have a dietitian see them and perhaps adjust their enzymes. We always want to measure their fat-soluble vitamins, which people with CF can become deficient in. So we really request that patients come in mostly so we can address their nutritional needs, make sure they're taking their vitamins, that their enzyme dosing is appropriate. We make sure that colon cancer screening is being done after transplant. There are different guidelines for CF than there are for the general population, and we want to make sure that's being addressed.